My name's Meg Tebbs, for those of you who I haven't met yet. I'm one of the third-year primary care residents, and so my talk today is on heart failure. So we'll go ahead and get started. If y'all want to keep your videos on so I can see you and we can interact, that would be great. Let's see how this works. There we go. Okay, so some objectives for this talk. So first, we're just going to go over some of the definitions and different classification models of heart failure. And then we'll spend a little bit of time talking about different etiologies and how we evaluate new diagnoses of heart failure. And then the bulk of this talk is really to review the guidelines for managing heart failure. And we're going to do some breakout rooms at that time and have you guys kind of review the guidelines for yourself and see what your takeaways are. And then I'll also provide some recent updates to those guidelines towards the end. Okay, so first, just starting with like the main definition of heart failure. So this is it's a complex clinical syndrome, and this can result from any structural or functional impairment of either ventricular filling, which is diastole, or ejection of blood, which is systole. And so all of us know the common terms of HFrEF and HFpEF, and so I just wanted to really clarify what those ejection fraction cutoffs are and kind of how we use these terms to talk about heart failure. So heart failure with reduced ejection fraction, or what we call HFrEF, really the definition is less than 40% as the LVEF. So this is also known as systolic heart failure. And so most of the clinical studies that have been done in patients with heart failure use this as a cutoff. Even some of them have even more strict EF cutoffs. It's more like 35% in a lot of the clinical trials. So that's what we'll spend the bulk of our chat talking about. And then there's also this huge group of heart failure with preserved ejection fraction, or HFpEF. This is kind of most holistically is defined as like diastolic heart failure, but at times it's a really catch-all term to include a lot of other things, like people use it to talk about like pulmonary hypertension and valvular heart disease and all these other things that have a normal EF. And then within that group, there's kind of this borderline area, which is people who have an EF between 40 to 50. So you can call this HFpEF borderline. There's also a term called HFmrEF, like moderately reduced ejection fraction. Some cardiologists like that, others will laugh in your face if you say it. So it's kind of a personal thing. And then the other kind of group is people who previously had a reduced ejection fraction. So at one point it was less than 40 and now they are improved or recovered. And in general, we tend to treat those people like the people with HFrEF, since at one point they did have reduced ejection fraction. Okay, so moving into some different classification models. So I'm sure you've all heard of the New York Heart Association functional classification, which we commonly use to describe kind of how bad someone's heart failure is just based on their symptoms. So class 1 is people who have cardiac disease, but they're not having any physical limitation in what they're able to do as far as symptoms go. Class 2 is really mild symptoms. So they're comfortable at rest, but when they're doing kind of around the house activities, they may have fatigue, palpitations, dyspnea, those kind of things. And then really class 3 is probably what the majority of our patients who end up in the hospital would fall into this category. And that's people who have really limitation of their physical activity. So even really common things like getting up from the couch to walk to the bathroom might result in dyspnea or fatigue. And then the last group is class 4, which is severe, and these people can even have symptoms at rest. So one of the big limitations of this model is that because it's based on symptoms, it can change over time. So even over the course of like one hospitalization, someone could come in with class 4 symptoms, and then after they're diuresed and put on medications, they could be down to class 2. So it's not as helpful as for guiding management, and really just tells us more about where their symptoms are at. So the ACC and American Heart Association came up with the stages of heart failure to kind of address this problem. And so you'll also hear this. I feel like clinically we talk about it less, but it's how a lot of the guidelines are written. So basically stage A is somebody who's at risk of developing heart failure but doesn't have it yet and doesn't have symptoms. Stage B is somebody who has structural heart disease, but they're not having any symptoms of heart failure. And then stage C is when you have structural heart disease and you have symptoms. And then stage D is more advanced heart failure. And so kind of combining these two systems together, you can see how they fit together. Really, stage C is what we're managing clinically. And that kind of represents the New York Heart Association classes like 2 through 4. Occasionally you'll hear people talk about class 3A and class 3B, and that's kind of whether or not they've had dyspnea at rest recently. So those are our different classification models. Again, I think clinically you'll mostly hear people talk about the New York Heart Association classes. Okay, and then just briefly touching on some pathophysiology of the symptoms of heart failure. I know we all see this all the time, and so we can really recognize the signs of it, but just in thinking about what's actually happening, there's kind of 2 processes going on. One is an issue with forward flow or reduced cardiac output, and so that often causes dizziness. Because of the decreased blood supply to the kidneys, you get activation of RAS and aldosterone release, and that increases your increases vasoconstriction. You get increased a sympathetic response, and that also leads to vasoconstriction. And all of these things provide less blood to the muscles, which makes you feel tired and exhausted when you're trying to exert yourself. The other side of things is the matter of venous congestion, kind of backup of blood in the body. And so that's when we start seeing things like pulmonary edema with left-sided heart failure. Particularly in right-sided heart failure, we still see a lot of hepatic congestion. You can actually get cardiac cirrhosis from backup of blood into the liver. You can develop ascites, lower extremity edema. We see elevated JVD as a common manifestation of that. And then so just briefly to touch on some epidemiology, this is one of the most common reasons that people are hospitalized in the United States. It has a really high mortality rate. The absolute mortality is about 50% within 5 years of diagnosis. And unsurprisingly, some of the main risk factors are hypertension, diabetes, metabolic syndrome, any kind of atherosclerotic disease. And so the big etiologies, far and away, the most common cause of heart failure is ischemic heart disease from coronary disease, prior myocardial infarctions. We certainly see that a lot. And then the other kind of big catch-all group is this term called dilated cardiomyopathy. Another term that you'll hear is non-ischemic cardiomyopathy, and I'll go through all of the things that can cause that. But other common causes are valvular heart disease and hypertension, which often leads to diastolic problems because this is a kind of a massive slide, and it's meant to be overwhelming just so you get a sense of how many different things can cause dilated cardiomyopathy. So this is really kind of another catch-all term that really just says that you have ventricular dilation as well as decreased myocardial contractility in the absence of either hypertension and valvular disease. So some of the most common causes of this are toxins, so both alcohol. We see a lot of methamphetamine-induced cardiomyopathy here in Seattle. And then oftentimes people are called idiopathic, but more and more we're learning that these are kind of falling into more genetic and familial cardiomyopathies. So that's this other section that I have highlighted. And then there's just a whole host of different infections that can cause it. So a bunch of viruses can cause myocarditis that can result in dilated cardiomyopathy. There are deposition diseases like amyloid and hemochromatosis. You can get autoimmune processes like scleroderma, sarcoid, thyroid disease. Thyroid disease is often hyperthyroidism, and that typically causes a tachycardia-induced cardiomyopathy in the same way that like uncontrolled atrial fibrillation with RVR can also cause like a tachycardia-mediated cardiomyopathy. So just looking at this slide, you kind of get a sense of all the things we go digging for when we're trying to understand why somebody has heart failure, if it's not the most common cause, which is ischemic heart disease. So when you're evaluating somebody who you suspect has heart failure, they're coming in with dyspnea, lower extremity edema, fatigue, all of those things, you're going to want to try to get a sense of their family history, ask them about drugs, alcohol, prior medications like chemotherapy, and then really just trying to get a sense of the severity of their symptoms, screening them for other kind of comorbid conditions like obstructive sleep apnea or central sleep apnea. And then really, because this is such a chronic illness that requires a lot of partnering with these patients, just getting a sense of where they're at as far as medication adherence, because that's going to help guide some of their decisions that you're making as far as which medications to choose. Okay. And then physical exam, as internists, we do this all day, every day as far as our volume exam. So you want to first think about where is this patient's weight in regards to where they used to be. That kind of can give you a sense of how volume up they are. You can look at their blood pressure. We do JVP exams. We listen for murmurs. We think about their PMI as far as if they have, if that's displaced, suggesting a cardiomegaly or dilation. You can feel ventricular heaves for people at times, and then other just signs of volume overload with pulmonary crackles, decreased breath sounds that suggest effusions, edema, ascites, all of those things. So to touch briefly on this JVP exam, which we do all the time, and it's kind of like the crux, like as much as we do it, we still have a hard time with it because some people just have hard neck exams. So this is how I was taught to do it. I was actually given a little ruler in medical school on the day that they taught us how to do the JVP exam. But how many of us actually do it like that? Probably not very often. We're kind of like guessing. We're like, is this 9 centimeters? Is it 12? I don't really know. So the way that I prefer to do the JVP exam is kind of more of a binary thing, like is it elevated or is it not, rather than trying to actually guess their right atrial pressure. So the way that I do this, especially in the hospital with somebody with known heart failure, is by sitting the patient upright totally, pressing on their liver and doing a hepatojugular reflex, and that really will show me where their internal jugular vein is. And then saying if it's above the clavicle, then their right atrial pressure is at least 10 centimeters, which is elevated. And then remember, just things we're looking for are it being biphasic, and then also having respiratory variation. Any questions or comments about that?
Can you just review like the hepatojugular? I can't remember like what that exam is.
Yeah, basically you just press on the liver. So right upper quadrant, just apply pressure, and what that does is it just pushes blood up from the IVC up into the jugular veins, and so it distends the internal jugular vein, and so it's more prominent and you can see it.
Is it not supposed to like go down or something like that?
Yeah, and so if it remains elevated, that is a positive exam for reflux. But even if it's not a positive hepatojugular reflux exam, you can still use that test to like identify the IJ. Does that make sense? It's kind of like a cheater to be like, okay, let me get it big and plump so that I can actually see it. And then as you watch it go down, you can try to figure out where that meniscus is. Yeah, the key to this is just practicing over and over. And then still sometimes it's hard, which is how I feel about it. Okay, and then so just initial workup for somebody with a new diagnosis of heart failure, just like basic labs. We want to know what their kidney function is. We want to know what their LFTs are. We want to know what their potassium is. Often check magnesium. Thyroid is like an easy low-hanging fruit thing to get early on, as well as a lipid panel to kind of risk stratify them. And then a BNP can be really helpful early on, especially if you're trying to evaluate different causes of lower extremity edema. That can really point towards more of a cardiac cause. And then just a baseline ECG, and then really your money's at that echo. And so that's oftentimes one of our very first tests. Guidelines say that we should get a chest x-ray. I would argue you don't really necessarily need it depending on what your kind of clinical suspicion is. And then the question is like, what kind of heart failure do they have? You know, in the right clinical setting, it feels like, man, this is slam dunk for ischemic heart disease in an older person with diabetes and hypertension. And so you're going to move pretty soon onto an ischemic evaluation. And so that's often a stress test as your first test. You can also do like myocardial viability studies, which is really helpful in thinking about revascularization for these people who do have ischemic heart disease. There are some studies that suggest that that can actually improve ejection fraction if you revascularize people who have a low EF. And then other things to think about looking back at that huge list of all the things that can cause dilated cardiomyopathy, you're going to start with some iron studies, screening them for HIV, SPEP, UPEP, kind of autoimmune evaluation, depending on the rest of their clinical picture. And then cardiac MRI is often very helpful, especially when we're thinking about more infiltrative processes to get a sense of, is there inflammation within the heart muscle itself?
Okay. I have a question. What's the viability study? Is it like the myoperfusion?
Yeah, exactly. Yeah, it's like the myocardial perfusion. It's a nuclear medicine study. And, you know, it has its own limitations, but it can kind of, there's ways that they can, you know, look at that uptake and figure out, is that tissue dead or does it still have, is it more like hibernating myocardium? Cool. Okay, so next we're going to go into management, which is kind of the beef of this talk. There's a couple of points I want to make first, and then I want us to break into groups and spend some time kind of going over the main medications we use for heart failure and really get a sense of how we prescribe these, especially in the outpatient world. Just a couple of things on lifestyle for patients with heart failure. We're going to be talking to them about fluid restriction and salt restriction, often like 2 to 3 grams for these people. I think we're really critical on our heart failure patients about their diet. And I think it's just important to be mindful, like they crave salt because their kidneys have decreased blood flow. And so they kind of have that intrinsic mechanism that makes them crave salt. And unfortunately, you know, it does cause them to retain water worse. I certainly have a high salt diet. I love fried chicken and all of those things. So just trying to approach our dietary counseling with a lot of compassion for these people. And then also just cautioning folks, a lot of times they'll use salt alternatives, which a lot of them have a lot of potassium in them. So especially for people who have any kidney dysfunction or who are on spironolactone or other medications that raise your potassium, you have to be really careful. And then cardiac rehab is a great thing for people who are symptomatic and are interested in becoming kind of like improving their functional status, and improves quality of life as well as mortality. And it is often paid for by insurance, which is great. And then just as far as other lifestyle things, making sure you're screening for sleep apnea and treating that with CPAP. And then, so as we talked about stage A, as far as the guidelines for managing stage A, it's really not much because these are people who are at risk of heart failure but don't have structural heart disease yet. And so really at this point, we're just controlling their comorbidities, making sure their blood pressure is under control, managing their lipids, their diabetes, working on weight loss and those things. And then getting into stage B, this is people who are asymptomatic but do have structural heart disease. For people that already have a reduced EF, you want to start them on ACE and ARB and a beta blocker. And then if they have a history of an MI and reduced EF, you're going to be using statins. And of course, blood pressure control is kind of important for every step. Okay, so next we're going to go into guideline-directed medical therapy for stage C. You'll hear this term GDMT or often used, and this is just the term that cardiologists use to talk about the medications that have proven benefit in patients with heart failure. So did everybody get my email this morning? I attached a PDF to you guys with the guidelines. So we're going to break into some groups. It should be 4 groups total. And Whitney's going to help us here with the breakout rooms. Basically, so I want group 1 to look into the guidelines for stage C and read about diuretics. Group 2 is going to do ACEs and ARBs. Group 3 is going to do beta blockers. And then group 4 is going to do aldosterone antagonists. And then so really my goal, I think there will probably be about 3 people per room. The idea is that you'll find the section of the guidelines that talk about your particular medication. These all start around page 1, or it's like 173.
And then just bake my own and season them myself. Yeah, it sounds so good.
Anyways, so, oh, sorry, let me go back. Sorry. So things to think about after you read your section and that I want you guys to talk about amongst yourselves is there a mortality benefit for this medication? What does the data say about what it's helping? Is it just symptoms, hospitalizations? And then what medications do we select? So this is where I want you guys to talk about really what you see people doing clinically, what are our medication doses that we're starting with, and then what do we need to think about as far as lab monitoring. Okay, so I am gonna see if Whitney can help us out with going into the breakout rooms now. We'll plan to reconvene in about 10 minutes or so. So let's see what time it is. And I can't see the time because I'm in prison. I think it's like 9:30-ish. So we'll plan to come back at 9, maybe like 9:40 and go over everything at that point. Does that sound good? Okay. Whitney, ready for groups? Okay, we're good. Okay, is everybody back? Seems like it. Okay, so let's get started with the first group who talked about diuretics, particularly loop diuretics. So does somebody from their group want to share what their discussion was and what y'all took away from the guidelines?
I can talk about it if you guys want.
Great.
All right, we couldn't remember the questions after we switched the screen. But
I'm sorry. Email it out. That's okay. You can just tell me whatever y'all chatted about.
There was no known mortality benefit with using loops, but they were helpful in symptoms. And it was the drugs that we would use would be loop diuretics, and they said that like furosemide was the most common one used, but you can use like budesonide or torsemide. And the goal would be to eliminate clinical evidence of fluid retention.
Mm-hmm.
Dose-wise, you'd start at a low dose, and then you'd increase it until you got an appropriate response, which would be about losing a 0.5 kilo to 1 kilo of weight per day until the symptoms are improved, and then you kind of back down to maintain the weight once they're at their goal weight.
That's awesome. Yep, I don't have much to add. I'll just kind of give you my little summary slide from that section, which is exactly what you said. There's no mortality benefit, but it is helpful for people's symptoms. And big things to think about, we're often going to reach for Lasix first. But when you get advanced heart failure, you start developing gut edema, and so that decreases your absorption. And so Lasix is harder for you to absorb, and so at that point, we often switch to torsemide or Bumex for better absorption. And then really for people who are quite resistant to diuretics, and this is often, again, in pretty advanced heart failure, we have to think about like double blocking the nephron. And so we'll add on a thiazide diuretic in addition to the loop, and often we reach for metallozone in that setting. So some people are on metallozone as an outpatient. It's quite risky in terms of hypokalemia. And so oftentimes we do it in the hospital where we can like monitor them really closely, oftentimes with like twice daily BMPs to make sure we're not over diuresing them in terms of their electrolytes. And so really we're going to be reaching for Lasix first. In somebody who has pretty mild heart failure with just a little bit of volume overload and they also have bad hypertension, you might go for a thiazide like chlorthalidone or hydrochlorothiazide before you would reach for Lasix, just because those medications have a little bit better blood pressure control. So these are things to think about. Okay, and then I just wanted to give you guys this little visual. You may be familiar with it. It's just kind of the conversion chart for switching between different diuretics. And so really the only medication that has a different IV to oral ratio is Lasix. So you always want to double it when you're, or I guess the IV is twice as potent as the oral. So oftentimes when people come to the hospital, we kind of double their home dose. So which would basically be giving them the IV dose of what they're on orally. Other tricks that you may have heard for trying to guess what somebody's thresholding dose would be for Lasix, depending on their renal function, some people say the creatinine times 20. So say their creatinine's 2, you would want to give them 40 of IV Lasix. Another trick is to double the BUN. So those are all kind of just approximators for deciding how much dose of diuretic they're going to need based on their kidney function to threshold and actually put out urine to that dose. Okay.
Do you usually add metallozone after you use maximum dose of the loop diuretics, or?
Yeah, that's a really good point. So when to add metallozone, you're exactly right. I think it's when you're kind of maxing out your doses. If you're on like 4 of IV Bumex and they're not putting out, that's usually when we reach for metallozone. The other option is if you're like on a drip and you just aren't meeting your goals, you can reach for metallozone. Some people do like as needed metallozone at home, like where they take the same dose of Bumex or torsemide every day. And then if their weight goes up by 3 pounds, they might take 1 dose of metallozone. So that's more of like an outpatient use of metallozone. Not many people are on daily metallozone. You have to have pretty advanced heart failure to need that kind of level of diuretic. Great question though. Okay. Okay, group 2, tell me what y'all learned about ACEs and ARBs.
Yeah, so for ACEs and ARBs, I mean, I guess first, it's ACEs and ARBs, but, typically you start with an ACE inhibitor, and it's really the ARB comes into play when they're ACE intolerant. As far as kind of going through some of the questions you had, mortality benefit, yes, there is a mortality benefit to ACEs and ARBs, and it really applies to all HFrEF patients. So any patient with HFrEF, you really want to be starting on an ACE and an ARB. There's also a reduction in hospitalizations.
Yep.
As far as we talked about kind of some considerations as far as when to potentially avoid an ACE and ARB. History of angioedema would be a reason to avoid ACE. And then pregnancy or planning to become pregnant was mentioned. But otherwise, all patients you could really consider or want to start if they have HFrEF. And then as far as kind of medication selection, really there's been no evidence to choose one ACE over another, but you could start with like a lisinopril, an initial daily dose of 2.5 to 5 milligrams, and kind of titrating up gradually. I think the maximum dose they listed was 20 to 40 milligrams for lisinopril specifically. And then as far as lab monitoring, you do want to check renal function and potassium 1 to 2 weeks after initiating ACE and ARB. And then they just kind of in the recommendations, they say, check periodically. They don't actually give a specific timeline for when to continue to check renal function and potassium. But I imagine as you're titrating up, it might be reasonable to continue to check.
Absolutely. So those are all awesome points. Thank y'all for being so thorough. So just a couple of things to highlight. Really the key here is trying to get to the maximally tolerated dose. because that's where you're seeing the benefit. So the clinical trials, the doses of lisinopril that they were using was like, I think on average about 35, which is almost maxed out, with 40 being the kind of maximum daily dose. Enalapril was around 15, which is close to the max dose of 20. So totally agree. Start low. Heart failure patients just do not tolerate the like typical starting doses that we do for just regular hypertension. And so you really need to be seeing these people back in clinic very frequently. Oftentimes they'll come in every 1 to 2 weeks, and you're reviewing their blood pressure logs and up titrating their lisinopril. And then every time you're making a dose change, you really should be checking their potassium and renal function about 1 to 2 weeks later. And then I just wanted to make a quick plug. Some of you have probably heard of Entresto or sacubitril valsartan, which is a medication that had a study that came out back in 2014 called Paradigm. I'm going to tell you a little bit about how it works and kind of our indications for using it. So essentially, sacubitril is a neprilysin inhibitor. And so basically in heart failure, you have all of these endogenous vasoactive peptides. These include like bradykinin and natriuretic peptides. And so basically with the neprilysin inhibitors, you're blocking those. And so that helps decrease the neurohormonal activation, decrease the vascular tone, improve the cardiac fibrosis, decrease all of that remodeling that happens, as well as the sodium retention. So that's the mechanism of action with this medication, sacubitril. The trial Paradigm that came out back in 2014 was one of the first positive mortality benefit heart failure studies that we've had in quite some time as far as a new medication. Everything else that we've tried has been negative. So this compared sacubitril valsartan, which is an ARB, to enalapril, which is an ACE. And as you can see here, there was a mortality benefit. This was cardiovascular events and death combined endpoint. The big criticism of this trial is that it wasn't really an intention to treat trial. And so basically what they had, all of the 10,000 people in the trial, they had them try both medications before they actually randomized them. So they made sure that they could tolerate it. The big issue with sacubitril valsartan is the blood pressure lowering effect. And there's just a lot of patients with heart failure that just can't tolerate it. So that's one criticism. It's a great medication if you have the blood pressure room, but for some people with bad heart failure, they just really can't tolerate the blood pressure effect. So really the idea is to start low and go slow. This is because it's a combined medication. The doses are like 2 numbers, so it's 24 and 26, and usually start with BID dosing, and you want to increase it every 2 to 4 weeks. You do, if you're stopping like lisinopril or any other ACE inhibitor, you need to do a 24-hour to 36-hour washout period. So you'll have them stop their lisinopril, take 2 days off, and then start the Entresto. If they're already on an ARB, you don't have to do that same washout period since it already has the valsartan in it. And then really the recommendation I've heard from a lot of cardiologists is to go ahead and anticipate that they're going to have the blood pressure lowering effects and may not tolerate it. So cutting back on their diuretics can make that transition go a little bit easier. And this medication does have a little bit of a diuretic effect with the sacubitril. So that can be helpful for getting people to tolerate this medication. Okay, beta blockers.
Yeah, so there's 3 different beta blockers that are approved to help with reduced ejection fraction in heart failure. That's metoprolol succinate, which is the long-acting, carvedilol, and bisoprolol. Mm-hmm. Look at the questions of what they are. Yeah, so as far as like, is there a mortality benefit? Yes. They did MERIT trial in 1999 that showed, that kind of looked at metoprolol versus placebo, which showed a reduction in all-cause mortality. And then they did another trial for carvedilol, which is called Copernicus, and that was in 2002. It showed similar results. Bisoprolol is more commonly found over in Europe, so it's not really found here in the US. But So like starting doses for metoprolol would be like 12.5 milligrams or 25 milligrams with a dose, goal dose of 200 milligrams QD. For carvedilol, it's 3.125 milligrams to start with a goal of 50 milligrams QD. And then if you were in Europe or decides to come over here in the US, you would start with, for bisoprolol, 1.25 milligrams QD with a goal of 10 milligrams QD. There are no labs that you necessarily need to follow. I guess the more I think about it, like what drug would you initiate? I guess if they're, I guess in theory, like if they're like using cocaine or meth, then I would probably want to do something like carvedilol, maybe because of that unopposed alpha effect. But yeah, I don't know. I'm not really sure about like COPD individuals. I've heard that's just kind of like a myth, but I would still try to start it to see if they tolerate it.
Yeah, those are all great points, and I totally agree. I think so. As far as choosing between carvedilol and metoprolol, it often just comes down to blood pressure. People who have higher blood pressures, we usually choose carvedilol for, and people who don't have as much blood pressure room choose metoprolol. I think COPD, we don't need to be avoiding these medications. It's particularly more like asthma and more like reactive airway disease that we have to be a little bit careful, but oftentimes people can still tolerate it as long as they don't have really severe asthma and are not like in an acute exacerbation. Big risk is bradycardia. And so thinking about that, checking people's heart rate, and that's going to be kind of your rate limiting step when you're trying to uptitrate this medication. Okay, and then the last group, aldosterone antagonists.
That's me. So aldosterone antagonists, they're like really mainly two: the spironolactone and the eplerenone. Both have been shown to cause an all-cause or decrease all-cause mortality in the range of like 30%. And in terms of when you would really initiate them, they're kind of considered not necessarily third line, but they would be your third medication that you would add if the like usually after a beta blocker or an ACE or an ARB. In terms of choosing between the two, spironolactone is kind of the first or the most common choice to initiate. Eplerenone usually has been associated with fewer side effects, particularly gynecomastia. The other major severe side effects that you need to be concerned about is hyperkalemia. So you monitor usually at least 2 times after initiating, like a couple days after and a week out, to monitor for that. And then in terms of, am I missing anything? I think that's generally.
That's it.
That was it. Yeah.
Yeah, totally agree. We're going to start this medication after they're already on the beta blocker and the ACE or ARB. Hard cutoffs are like creatinine greater than 2.5 in men and 2 in women, or potassium's over 5. And I agree with all the lab monitoring that you said. I just have a few other slides to run through really quickly at the end here. You may have noticed in the guidelines there is a section for talking about isosorbide, dinitrate, and hydralazine. My personal opinion, and I've talked to a couple of cardiologists about this, I think the data is really questionable. The recommendation is to consider this in African American patients, but this was all post-hoc retrospective analyses. And so I don't think the data is there, and I don't think that we have the clinical trials to suggest changing our management based on race, and especially with the methodology that they used in these studies. So that's my 2 cents. You'll find people who feel differently, and that's okay. And then just a quick note about digoxin, there's no mortality benefit. The big time that we think about using it is people who are having a hard time controlling their atrial fibrillation, or who are kind of end stage heart failure, who are symptomatic and they're kind of already maxed out on all their other medications that can provide some symptom benefit and some quality of life. It's just a really narrow therapeutic to toxic ratio, so you have to be careful. And then other interventions that we think about in people with heart failure with reduced ejection fraction, so people who have an EF less than 35 and they're post-MI, we think about ICD in these people. And you really want to be thinking only in people who have greater than a 1-year life expectancy that has mortality benefit. You'll also hear a term called CRT, which stands for cardiac resynchronization therapy. And so this is for people who have conduction abnormalities in their heart usually because of prior myocardial infarction. So people who have like left bundle branch blocks with a widened QRS. So it's an indication if their QRS is greater than 150 milliseconds, they qualify for cardiac resynchronization therapy, which is really just a biventricular pacer pacer. So basically it synchronizes their right and left ventricle. So they're contracting more like they would had they not had these conduction abnormalities, and that can improve the ejection fraction and symptomatic benefit there. So here is just a summary slide of all of the things that we've talked about. First things that you're reaching for are the ACEs and ARBs, as well as a beta blocker. And then you're considering switching if they're tolerating these medications in terms of blood pressure. You're thinking about aldosterone antagonists, maybe hydroxynitrates. Hold on, sorry y'all. Okay, there we go. And then once you start getting into this category of more refractory symptoms, these people are going to be mostly managed by cardiology. I'm actually going to skip this slide because I don't think it's that important. Big medications to avoid are calcium channel blockers in people with reduced ejection fraction, particularly diltiazem. So do not reach for that for atrial fibrillation rate control in people who have a reduced EF. Amlodipine is probably okay as far as blood pressure, but because of the edema and everything, it's not usually the best medication. Try to avoid NSAIDs. We don't really use this medication anymore, an old diabetes med. And then this slide is just to say that we don't really have much for HFpEF. Like all of these trials and all of this mortality benefit is in people with reduced ejection fraction. So really we're just controlling their blood pressure and then giving them diuretics to control their symptoms. Okay, so this is just my take home slide. I will save our last minute for any questions that people have. Someone made a comment of specifically an EF less than 35 for a calcium channel blocker, which is right.
At what point do you refer to cardiology?
Yeah, so I think anyone with a new diagnosis of heart failure should see cardiology at least once. Oftentimes they're seeing them for their ischemic evaluation. If there's any question of what the cause of their heart failure is, they definitely need to see cardiology. Oftentimes in people who have like stage C, kind of early, well-controlled heart failure, it will be the internist that manages it day to day, and maybe they would see a cardiologist annually. So as internists, we definitely end up managing this, but I think involving cardiology sooner rather than later is always a good idea.
So for the HFpEF, I know you said there is no mortality benefit for any of these medications. So does that mean we don't use any of these medications like in practice?
Yeah, so the reality of it is that oftentimes people have other indications for things like ACEs and ARBs and beta blockers. So because atrial fibrillation is so common, because coronary artery disease is common, people with HFpEF often end up on these similar medications, but specifically in looking at mortality benefit for people with just HFpEF, it hasn't really been shown. I will say there's a study called TopCat that came out a couple years ago. Oh, okay, we gotta stop. I'll just say that some people use spironolactone in HFpEF. Sorry, we're out of time.
Oh, here's what, sorry guys. Hey, it's Carolina. I'm the next presenter. You feel free to ask questions, and Whitney, we can start at 10:10, but if you guys need a break, then I would go take a break, but otherwise these are wonderful questions that you're all asking Meg. So whatever you need to do to re-energize.
And I'll keep an eye on the chat box if anybody else has questions.
Hey Meg, is Entresto generic? Do you know?
It is not.
I don't think so.
I
Is it
think
pretty
it's still
expensive?
a name brand. The VA covers it, so you'll probably see it mostly used there. It's expensive, yeah. I think outside of the veteran population, it's often kind of cost prohibitive, but it is. I think some like private insurance companies are paying for it for heart failure.
Cool. Thank you.
I had a question, possibly a little too specific, about HFpEF and AFib. I had a patient in clinic yesterday who actually came in with volume overload and was found to be an AFib. And in terms of, it always seems to be a chicken and the egg scenario of like what caused what. Was it the AFib that then caused the overload or vice versa? And in terms of like HFpEF, what, like, I always assume, like, I always kind of think of heart failure as an irreversible diagnosis.
Mm-hmm.
To address the underlying AFib, would you still consider them to be in heart failure if it's a clinical diagnosis of volume overload, as opposed to something more structurally like obvious in something like a diastolic or a dilated heart, like heart failure, or like heart failure with a reduced ejection fraction? How permanent of a diagnosis
Is HFpEF?
Yeah.
Yeah, I think that's a good point. I think really it's a clinical diagnosis of someone who has a normal ejection fraction or greater than 50 who has symptoms of heart failure.
Okay.
So not everyone who has diastolic problems on their echo has HFpEF. Does that make sense? So I think you're exactly right in thinking about like treating the underlying structural heart disease if it's AFib, if it's a valvular problem, rather than trying to treat the HFpEF itself. It's more about addressing the underlying structural heart disease. Okay, I'm out of time. I took more than my share. Thank you, Carolina.